The case is called Keeping the Grim Reaper at Bay. I'll be presenting on behalf of medical oncology. First case, we'll just look at 2 cases and go through that. First case, February 2016. 48-year-old gentleman, teacher by profession from Andhra Pradesh, presented with left shoulder pain and low backache for the last 3 months. There was no symptoms suggestive of an inflammatory low backache. He had significant loss of weight and loss of appetite. He was a non-smoker. There was no family history of malignancy. On examination, his vital signs were stable and he had heart swelling over the left scapula. This is his initial presentation at another center. Evaluation at another center had shown a large lobulated soft tissue enhancement in the perihilar region of the left lung and hypermetabolic multiple nodes including the mediastinal nodes. Histopathology from the lung mass was reported as adenocarcinoma of the lung with predominantly SNR pattern, at which point in time he had received palliative radiotherapy for his painful scapular lesion elsewhere and come here for further continuation of care. Next case, July 2018, about a couple of years later, Mrs. A, she's a 50-year-old housewife from Uttar Pradesh, presented with cough, breathlessness and exertion, loss of weight and loss of appetite for 2 weeks duration. There was no history of fever. There was no history of tuberculosis in the past or contact with tuberculosis. No family history of malignancy. On examination, her vital signs were stable, right massive pleural effusion. She was also evaluated along the same line. CT thorax had shown a right parahilar mass with collapse of the right upper lobe, suggestive of a lung malignancy, and multiple soft tissue nodules along the parenchymal lung. Histopathology is reported as adenocarcinoma. So final diagnosis is a non-small cell carcinoma of the lung, stage 4 metastatic adenocarcinoma. She was evaluated for a mutation and she was found to be having EGFR mutation positive. So what next? Should we just let her go back, best palliative care, or is looking for halting disease progression or cure too far-fetched? So what did we do? So Mr. M was initiated on first generation EGFR TKI. This was in 2016. By 2017, he had progression of the disease and he was started on cisplatin and pemetrexed and followed by maintenance. Subsequently, his disease regressed till April 2018. We will go back to, at the end of the presentation, we will see what happened after April 2018. Mrs. A was also started on first generation EGFR TKI. Initial improvement and stable disease till March 2019, and we shall look at it at the end. So why did we do what we had done? This presentation focuses mainly on EGFR TKI in the treatment of non-small cell lung cancers. So this is just an image showing the driver mutations in the lung carcinoma, and you can see about 64% of them had a driver mutation, which means we could possibly try and have a targeted therapy. And the one in the focus of our discussion right now is the EGFR mutation, which is present in 17% of all those with lung adenocarcinomas. EGFR is a cell surface receptor, and after the ligand binding, it changes from an inactive monomer to a heterodimer or a homodimer. Subsequent dimerization causes activate of the tyrosine kinase pathway and tyrosine autophosphorylation. So this autophosphorylation causes downregulation and activation of the AKT pathway, which is the one that is responsible for cell cycle progression proliferation. So this is just to quickly look at the mechanism of action. This is the ligand binding domain and the tyrosine kinase binding domain. So when there is a attachment of the ligand, so there is dimerization. So when you have the dimerization, there is downstream signaling which causes reduced apoptosis, where there is resistance to apoptosis. There is uncontrolled proliferation causing malignancies. So like I said, mutation of these family causes epithelial cancers. Mutation involving the EGFR TKI leads to persistent activation of these downstreaming pathways, resulting in uncontrolled cell proliferation and hence malignancies. So theoretically, EGFR TKI are useful for treatment of lung cancers with those with sensitizing mutations. So these are the EGFR tyrosine kinase inhibitors that are currently available. The first generation ones are alertinib and geftinib, second generation afatinib, and third generation osimertinib. This is just to quickly run through the study that's presented in the lung cancer respect 2013, irreversible EGFR TKIs. This is just to show the mean progression-free survival in about 7 studies looking at the progression-free survival comparing EGFR TKI versus chemotherapy, which is the standard of care till recently. So if you can look at it, there has been a progression-free survival for about, on an average, about 10 months. So now we will just look at a meta-analysis that is looking at single agent EGFR, whether given upfront or after a course of chemotherapy and progression, or as a maintenance. So this had looked at 23 eligible trials. So all of them had a hazard. Just the crux of the matter is that there's about the hazard ratio is about 0.43 when you have used an EGFR TKI drugs. So how do you use this in a clinical setting? So advanced non-small cell carcinomas that contain this mutation are highly sensitive to these drugs, and the need for routine analysis for the presence or absence of these driver mutations for the initial treatment to guide the management. The EGFR incidence ranges from about 20 to 62% and is more common in non-smokers and women. So that will give us the benefit of treating those who don't have the traditional risk factors of smoking. The next thing to note that is the incidence of these mutations is highly variable based on the ethnicity. There seems to be an increased incidence of these particular mutation in our population, the Southeastern Asian population. So why do we even have the second generation if all is well with the first generation? So they have noted that about 37% of the population with non-small cell do not respond to the first generation ones. But if they have uncommon ones, so there's anyways no benefit. Toxicity, there's not definite cure, and there's lack of efficacy in the presence of acquired ones, which we shall deal with. So over the subsequent course of time, we had realized that the patients were not sensitive to the first generation one, and we had looked at why so. The three common mechanisms that were proposed is the most important one, and the talk would be on emergence of a mutation in the domain EGFR gatekeeper domain, which is called the T790M. So basically there is not going to be binding of the EGFR TKI, and hence the whatever is supposed to be downregulated is now cancelled off, and there is an upregulation. So that is the most common mechanism that has been proposed for resistance to first and second generation EGFR TKI, and hence the development of a third generation TKI. The available third generation EGFR TKI, osimertinib, it's an oral drug, irreversible EGFR tyrosine kinase inhibitor, and selected for all those with this particular mutation, which is the T790M. Currently validated for use in locally advanced or metastatic non-small cell carcinomas. This is an article presented in published in NEJM April 2015. They had recruited 243 patients. So in subgroup of patients who had this particular mutation, which is T790M positive, the progression-free survival was about 9.6 months when they were treated with this. So they get an about extra 10 months as opposed to those who do not have this particular mutation. The latest one is the one published January 2018, which is a double-blind phase 3 trial including about 560 people. They had compared the third generation osimertinib with the first generation, which is geftinib. The primary endpoint was a progression-free survival. So we can see that the progression-free survival was 10 months, so which means you've added about 10 months, and the hazard ratio is about 0.46. And if we have to look at, so after all this, are they safe? Do people tolerate it well? So if you have to look at serious adverse effects, it's about 16.3, varying about 15 to 30% across three studies. But however, only about less than 10% had adverse effects leading to discontinuation of therapy, which means they are tolerated quite well. So just to summarize the thing, so earlier at the diagnosis, we were starting patients on first generation or second generation, and they had a disease-free progression for about 9 to 13 months, and subsequently they had chemotherapy. However, right now, when we put somebody on first and second generation, and they fail, now we know that we have an option, we have a second option, which is looking at the mutation, which is T790M. So at that point in time, when the mutation is positive, you could give them an option of third generation, prolonging their lifespan for another 10 months. And the next possibility is directly giving a third generation straight away. So coming back, Mr. M, last he was seen in April 2018. In August 2018, he had disease progression, and he was found to be having a mutation T790M of the EGFR gene. He was initiated on osimertinib, and currently is stable asymptomatic since then. So from diagnosis, he's been on therapy for the last 4 years and he's been asymptomatic. And Mrs. A in March 2019 had developed brain mets. She was evaluated. She was found to be having the same mutation, started on 3rd generation, and she's also stable and asymptomatic disease since then. Take home message. EGFR TKI's prolonged progression-free survival in patients with metastatic non-small cell carcinomas, and they are tolerated quite well. So in a situation like this, there is a need for analysis of the EGFR mutation at front. Although there has been no survival benefit in the current documented studies, all of them were done after a crossover. Initially they were on chemotherapy and later only they were put on the EGFR TKIs. So that might be one of the reasons as to why there has not been overall survival. Till now we have been only using 3rd generation after failure 1st and 2nd. There has been trials to show that this. So the take-home message at this point will be, if we had written them off and sent them off home saying best palliative care, might not be the best thing. So they had the option of living 4 years asymptomatic after diagnosis and a couple of years after diagnosis. Thank you.
Any questions? I think what she was trying to say, there were 2 patients. One was a gentleman who came in 2016 and he was given first line gefitinib, and then subsequently when he had disease progression, he was given chemotherapy. Metastasis, so which was biopsy, and there was 67 because of that we were able to give him osimertinib, and he had a response to that. So that was one example. The second example was a lady who initially presented with lung cancer who had an exon 21 mutation. She also had a baseline T790M. That didn't come out in your presentation, but we didn't give her the 3rd generation. We just gave her the 1st generation. But on that she did well for about a year, and subsequently she developed leptomeningeal disease and carcinomatous meningitis. And one of the features of these 3rd generation TKIs are they have a very good CNS penetration. So even in leptomeningeal disease, if you have a sensitive mutation, they do respond. So this lady actually was sent home on osimertinib, and in spite of having a carcinomatous meningitis, we know it's a very difficult disease to treat. With median survival of almost like in weeks, not even months. But she did well, and now she's almost 6 months now and asymptomatic. So yeah.